Hello dear colleagues, welcome to RetinaRA.org, a Vitreoretinal knowledge sharing platform. In this video we will discuss about the definitive diagnosis of a case who has previously been misdiagnosed as serpiginous choroidopathy and received systemic corticosteroid and methotrexate treatment. This case shared by Dr. Kemaltekin, whose Instagram accounts are @dr.kemaltekin and @retina.academy. This patient was a 33-year-old female under systemic corticosteroids and methotrexate treatment for serpiginous choroidopathy presented for a transition of care. Best corrected visual acuities were 20/20 in the right eye and 20/25 in the left eye. Intraocular pressures were 18 to 15 mmHg for the right and left eyes with topical dorzolamide and timolol treatment. Slit lamp examinations revealed posterior subcapsular cataracts in both eyes. Dilated fundus examinations of both eyes showed bilateral symmetrical bone spicule-like pigmentation and retinochoroidal atrophy along the retinal veins. Fundus autofluorescence revealed that both pigmented and atrophic areas appeared hyperautofluorescent, while the borders of the chorioretinal atrophy exhibited hyperautofluorescence. The hyperautofluorescent rim surrounding the hyperautofluorescent atrophy is thought to represent a hyperfunctional retinal pigment epithelium with lipofuscin accumulation, indicating a transition zone between healthy and degenerating retina. Horizontal and vertical optical coherence tomography scans exhibited atrophy of the outer retinal layers and retinal pigment epithelium in the paravenous areas with a normal foveal contour. Differential diagnosis is guided by clinical evaluation and multimodal imaging findings. The case exhibit regions of retinochoroidal atrophy tracing retinal veins with pigment accumulation varying from fine scattered deposits to pigment clumping and more severe bone spicule-like pigmentation. Paravenous lesion distribution is a hallmark of pigmented paravenous retinochoroidal atrophy, distinguishing it from phenotypically similar entities such as pericentral retinitis pigmentosa and serpiginous choroidopathy, which typically involve extraparavenous areas. Let us now examine the details of the differential diagnosis. The image on the right demonstrates our case, whereas the image on the left presents a similar case with different diagnoses for comparison. Serpiginous choroidopathy, a chronic inflammatory chorioretinopathy, presents with recurrent choroiditis marked by grey-yellow, well-demarcated infiltrates, extending radially from the juxtapapillary region to the retinal periphery. These evolve into zones of choroidal atrophy that may resemble pigmented paravenous retinochoroidal atrophy. Distinction is based on its progressive inflammatory course, which is often accompanied by vitritis or anterior chamber reaction, and its responsiveness to immunosuppressive therapy. The image on the right demonstrates our case, whereas the image on the left presents a similar case with different diagnosis for comparison. Pericentral retinitis pigmentosa is a segmental degeneration of the retinal pigment epithelium photoreceptor complex, exhibiting arcuate bands of atrophy extending from the peripapillary region toward the peripheral retina. Discrete foci of involvement beyond this trajectory provide a differentiating feature from pigmented paravenous retinochoroidal atrophy. The confluent form of pigmented paravenous retinochoroidal atrophy may, however, exhibit indistinguishable morphologic features, and only longitudinal follow-up may reveal the progressive degeneration characteristic of retinitis pigmentosa. In our case, multimodal imaging findings were consistent with the diagnosis of pigmented paravenous retinochoroidal atrophy, which is a rare condition characterized by atrophy of the outer retina and choroid, with pigment accumulation distributed along the retinal veins. Most patients are asymptomatic and identified through routine examination based on the distinctive fundoscopic appearance. Visual acuity is generally preserved or mildly impaired unless there is macular involvement. Pigmented paravenous retinochoroidal atrophy is considered slowly progressive or non-progressive. Therefore, distinguishing it from progressive pathologies such as retinitis pigmentosa, serpiginous choroidopathy, angioid streaks, tuberculous choroiditis, and frosted branch angioitis is essential.
You can share your interesting and educational cases on our website Retinara.org. Don't forget to click the like button and follow our channel to be informed about our new posts.